I'm going to show the acute triangle that I use for tibial nailing. It's a nice soft surface for the nailing procedures, and what happens is that the knee will be supported by this relatively stable platform. This can be brought onto the field because we have these custom bags into which the pieces can be placed. So you see how these just drop in as an inverted triangle and are maintained? The custom bag has this durable cover at the apex of the triangle. Again, quite stable, and the knee is allowed to sink into the acute triangle, providing stability. Now this is what we call the obtuse triangle, and I use this for retrograde because this is the angle that the knee needs to be at to pass a guide wire down the femoral canal, the reamer, and the rest of the instrumentation. So this angle, the obtuse wedge, is designed for retrograde femoral nailing procedures. Now, in the case of a retrograde femoral nailing procedure, one would typically, with a freehand approach, want the patient tipped up approximately 25 degrees. So this is a body wedge which really fits underneath the thorax and the buttock to tip the entire patient up during the procedure. The lateral wedge tips up underneath the thorax and buttock to be able to do that. Now, you can see how this is designed in such a way as to allow for two angles. If you want to bump the patient up at a very sharp angle, you put them against this surface. If you want to bump them up at a more gradual angle, you put them at this surface. So I will simply tip her up to the more acute angle in case we want to internally rotate the patient more. Depending on the patient's leg and hip alignment rotation, one might want to take advantage of this different angle. If I want to bump the knee up with some flexion, as one might want to do for either a retrograde femoral nailing or perhaps a femoral plating procedure, there is a range of size in the bumps that we can use, so you can prop it under the leg like so. These can be used in combination. There are custom bags that can accommodate them, and you can see that depending on the size of the patient, you can use one, two, or all of these. Here is the larger bump. Now the bumps are very important reduction devices. I'll demonstrate why. If one has a femur fracture in this region, in order to reduce the alignment of the femur fracture, one will want to adjust the bump perhaps to fit right under the fracture to support it appropriately. So this bump here is doing the reduction of the femur fracture. I'm going to demonstrate the leg elevator, and that's generally for cases in which we're working on injuries or fractures below the thigh. The first thing I'm going to do, because patients tend to externally rotate, is simply bump up the hip with one of our 5-inch cylinders by scooting the bump, like so. And now the foot is in a neutral position. This is the Bonefoam ramp, which we simply position under the leg like so, and this angle accommodates the buttock. This elevates the leg that the surgeon is operating on and takes the other leg out of the field for C-arm imaging. I would use this for ankle procedures and perhaps plating procedures of the tibia and of the fibula. And this is designed in a way to be able to go under the drapes or over the drapes in a custom bag. I'm going to demonstrate now, with putting a drape over it, that we're basically going to eliminate the other leg from the field. The operative leg is now elevated to allow clear lateral imaging. Without the ramp or stack of towels, the surgeon has to lift the leg, potentially malreducting provisional fixation. Here I'm simply going to demonstrate the placement of the leg elevator in a sterile bag. Some surgeons prefer to have this sterile feature so that the ramp can come onto the operating room table field and off of it. This allows the piece to be more portable during the entire procedure. You can see it has this nice durable feature for the working surface, and the rest of it is durable plastic. I'm going to be discussing one of our most popular pieces called the leg tunnel. We use it when we want to work on a leg while the patient's in the lateral decubitus position. Typically, the calcaneus fracture would probably be what it's more commonly used for, although it could be used for posterolateral bone grafting. And surgeons have gotten creative for other types of procedures as well. I'll describe the features of the leg tunnel. This is the undersurface, which is what the piece is named for, the leg tunnel. So this will accommodate the down leg. And I'm going to flip it over. This side will become the surgeon's working surface. The top leg, the leg in which the surgeon is working, will lay on top. This cutout here accommodates the groin. This is the Bonefoam leg tunnel too, because we built in these straps, which are attached by fasteners, and you can see that there are two straps. We can use these to hold and secure the piece down to the operating room table. I'm going to elevate the leg like so and push the piece up into the groin. This is essentially the width of the standard operating room table. Now you can see that the leg tunnel accommodates the down leg, and so the surgeon can check underneath and make sure that, for example, the bony prominences are well padded at the malleolus, and that the perineal nerve is also either supported or allowed to be suspended, so we don't get problems related to the perineal nerve. The tunnel is also off to one side, and that allows us to be able to image with C-arm, for example the calcaneus, like so, in a way that offsets the up leg from the down leg. So another strategic feature of the leg tunnel too is the up leg straps. There's one distal, and with Velcro straps, these can really be pulled and tightened quite securely. There's a more proximal one. In the past, the leg tunnel was secured to the operating room table with tape. This has been a significant enhancement that our surgeon clients seem to like very much. The leg tunnel is not sterile. This piece actually goes under the drapes. Some of our pieces are designed to go above the drapes or below the drapes, but this piece is larger, and it goes under the drapes. So what we do is cover the piece like so, and this becomes the surgeon's working surface. For the surgeon in this case, the calcaneus would be on this side of the table. We also feature in the Bonefoam line another type of leg tunnel called the Moon Tunnel 2. It has a more universal design. You can see here that there's one simple tunnel for the down leg. Some surgeons have simply expressed that they want something simple and narrower for patients in the lateral decubitus position. The Moon Tunnel could either be for someone who wants to work on the leg or calcaneus, or either more proximal, on the hip, as in for total joints, allowing for a more stable patient. It also has the straps, which can be used to secure the piece to the bed very effectively. What I'm going to be doing is showing our relatively new product called the Sacral Prop. We use this primarily for iliosacral screw fixation. It can also be used for anterior column percutaneous fixation in the pelvis. I'll demonstrate for a minute what has been typically done in order to elevate the patient's sacrum off the bed, so we can direct screws and drills from a posterior to anterior position. The reason that we design these pieces is to have the patient's sacrum come up off of the bed. It's for the supine technique, iliosacral screw fixation. Traditionally, what we did is folded up some sheets, like so, and propped it under the patient's sacrum. One of the challenges is that this technique has often caused the patient to be somewhat floppy because they can rock during the case and change position, and it's typically unstable. Now I'm going to show our new product called the Sacral Prop. You see, there is somewhat of an elaborate design here, and that is to allow the torso or the flank area to be cradled in this area, with these built-up edges to again support the flank. The prop piece actually details where the sacrum should be. The buttock, and of course this goes in the buttock crease, and there is an indicator here that says proximal and distal. What I'm going to do is slip this under the patient with this orientation, just like I've shown. We're going to lift the patient here, back down, and now the patient is very stable. So even if you're doing manipulations on the pelvis, you can see that the patient is built up very significantly. The buttock is hanging over the side here because we need to get posteriorly, typically at this vector, to get our iliosacral screw fixation. Or the other possibility is for anterior column screws that may go in this direction. Again, the surgeon has to drop their hand with the drill, or also to get from the pubic symphysis up the anterior column. For completeness, I'm actually going to show our entire Bonefoam line of prop positioners. This is a large, and this is a small, to accommodate the range of patients that we see. This can be used for the petite patient and even for patients up to 200, 225 pounds, typically. Based on the patient's morphology, that could change. This is a much larger one, which we would use for either the very large patient or the obese patient. Basically the same piece and features, but the other thing that's different here is that this is a disposable. So this is the open cell foam, non-coated, and it provides the same buoyancy, the same support. We have found that some surgeons prefer the disposable because they can get bloody and soiled, and these work well for that reason. I'm going to be setting up a patient in the lateral decubitus position so that we can demonstrate the upper extremity Bonefoam positioners. The first thing we want to do with someone in the lateral decubitus position is make sure that the axilla is appropriately protected. Bonefoam has the axillary bump, which is designed to protect the axilla. The axillary bump doesn't work with the upper extremity wedges, so we use this small cylinder for that purpose. So I'm going to scoot the patient up like so. This will rest right under her latissimus, leaving the axilla free of any pressure. The next thing I want to do is create a platform for the upper extremity wedge positioner. One can either use a hand table or these two arm boards side by side. Ideally, it is better to use something radiolucent so that you don't compete with any of the metal that might be in the arm boards. So this is the first Bonefoam upper extremity piece that I'm going to demonstrate. You can see that there's an offset tunnel and the narrow side goes up toward the head of the patient. It's narrower so that it won't be in the way of the endotracheal tube or in the way of the face, which allows for anesthesia to access the patient's airway. I'm going to simply scoot this up against the patient, like so. And you can see that we have this new modification of the block by cutting these corners in such a way to make sure that the endotracheal tube does not compete with the corner of the block. That's a recent modification. Now this would be something that I use for distal humerus fractures, possibly olecranon fractures. And some people prefer the elbow to just be at 90 degrees, like so, while doing this work. You can also see another feature is that because of the offset tunnel, the surgeon can manipulate the elbow to one side or the other while imaging, so that you get the opposite extremity out of the way. An alternative to this 90-degree position would be our upper extremity positioner, which allows for some extension of the elbow, which I will demonstrate next. This is again part of our upper extremity series, and you can see that there's a much larger offset surface here, yet there's still an offset tunnel. This allows us to be able to access the down extremity and protect it from the IV, and make sure the IV is not kinked, even allow anesthesia to access it. We're not burying it in blankets or towels like what was once done, so the upper extremity can then just simply drape over this upper extremity extended piece. Again, it has the cutout, which then allows for the endotracheal tube to not compete with the wedge positioner. These come in different sizes as well to accommodate both small and large frames. The upper extremity wedge and block in this case are under the drape, and I almost always use it that way. Conceivably, one could bring it in over the drape, but what I do is simply drape out the wedges in this fashion. I'm just showing a U-drape here. You could use an extremity drape as well. This is what the working surface would look like with the patient draped. I'm going to be discussing the newest member of our Bonefoam family, the gully. But before demonstrating this new product, I want to just demonstrate what we might typically use for an irrigation and debridement of an extremity today. Surgeons do different things, but it would not be uncommon to use a basin like this to capture the water. Needless to say, this doesn't necessarily capture a lot, and there tends to be a lot of spray. The field gets quite messy and wet, so what I'm going to do now is slip the gully underneath the extremity so that you can see the features of this new product. First of all, it's shaped like a gully, with an open cylinder to accommodate the leg. And it's built up just enough to be able to cut down some of the splash and to capture the fluid that will run out the end of the gully. To make it even more protective to the operating team, we have created a cover for the gully that can simply Velcro down, and if it's not desired, simply Velcro back. I'm going to show it Velcroed down now. And you can see there's a slit hole in the top, into which I can put a pulsivac and do a significant amount of irrigation, and this is going to trap the majority of the fluid. So I'll simply demonstrate now the use of a pulsivac with the gully, and what I prefer to do is cover the leg after I've completed my debridement, and then demonstrate how we simply put the pulsivac inside the slit. We can now perform our irrigation very effectively. You see that there's essentially no spray into the operative field. This also mitigates the risk of infectious contamination to the surgical team. I'm actually going to show an irrigation procedure using the metal basin that we typically might have used, and we can see that the surgery team gets sufficiently splashed. So you might try to cover it, but the reality is that it's a very messy procedure. Here I am putting the Pulsovac underneath the cover, and you can see that there's very little splash factor on the curtain, because it's all being contained within the gully.